kemudahan kepada kami untuk mendapatkan kesempatan melanjutkan pendidikan di kampus terbaik. Kami pun berkesempatan mendapatkan bantuan living cost.
Terima kasih OSC. Saat ini kami bersama jutaan pemuda lain siap menjadi generasi yang unggul dan berdaya saing untuk wujudkan generasi emas di tahun 2045.
Kami bisa, dan kini saatnya kalian.
Mari bergabung bersama Surya Edukasi Bangsa Foundation dalam melahirkan generasi unggul melalui pendidikan yang merata dan berkualitas.
Our bodies need fuel, but what happens when we aren't able to give our bodies the fuel they need? This can be described as malnutrition, a consequence of eating too little or too much of the wrong foods, or simply not getting enough nutrients. Specifically, undernutrition can lead to a cycle of poverty that is devastating. When a child is undernourished, it affects three main things. Their physical growth, like height and weight, can be stunted due to undernourishment. Their development, both mental and physical, can be delayed or impaired. Examples of impaired skills can include speech, walking, social skills, memory, and many more. Their immune system is compromised, making it harder to fight off disease. These adverse effects lead to poor productivity as these children grow up to become adults, and in turn reduces their economic potential. If this happens countrywide, it can affect a country's development and increase poverty. Likewise, poverty reinforces malnutrition by increasing the risk of food insecurity. And so now we have an unfortunate cycle between malnutrition and poverty. So how do we break this cycle? We can start by improving access to nutritious food, investing in smallholder farmers, and strengthening our food systems to withstand the impact of conflict, climate emergencies, and future crises. We can also put pressure on leaders right now to ensure a fully funded international development association so that everyone, everywhere, can keep their bodies fueled up.
Good morning, Indonesia, Southeast Asia, and the world.
So happy to be here as you start your day.
Do you remember the bend
And snap!
Oh my God.
And that concludes the See Today updates for today. We'll return for information at 4 o'clock on the 3-hour news show.
Welcome back to See the Stories.
Now time for See Today Business with me, Kaisuria.
Come see the beauty, only on See Indonesia.
Dari Madrid, saya stay 1 malam, terus besok paginya saya naik kereta ke Granada. Eventnya diselenggarakan di Granada, Spain.
Sebelumnya saya memang sudah hampir 6-7 bulan latihan. Mudah-mudahan saya bisa selesai dengan baik. Itu harapan saya.
Kita berjumpa lagi di konten ngobrolin tentang Nusantara.
Spot C, kedatangan very special VIP guest today.
Kan udah ditanya juga di situ.
Dia kan beda acaranya.
Back to the topic, guys.
This is a nutritious meal. It consists of a balance of essential food groups: grains, proteins, vegetables, and fruits. Now imagine your plate is swapped out for something like this. A meal consisting of just 1 or maybe 2 food groups. Not as nutritious, is it? This is the reality for millions of families in Africa and across the globe. Don't believe us? Check out these messages on the issue.
As someone from Ghana, where the average individual can't have good nutrition due to high cost of living, most families, especially in Accra, eat to survive the next day. And there's nothing like nutritious meals to these individuals.
Born and raised in an arid area of Kenya, I experienced malnutrition as a kid. We depended on relief food for the larger parts of my childhood, which was often just maize and beans.
With the escalating cost of essential food items in Africa, and presently in Nigeria, most families simply eat to survive without considering the complete range of food classes or nutritional value of their meals.
Millions of people on the African continent are being denied the chance to live healthy lives because they do not have access to nutritious food. Many families struggle to afford the high cost of fresh fruits and vegetables for a healthy, active life. Furthermore, farmers are dealing with never-ending droughts and floods that have devastated farming communities, affecting harvests. Close to 41% of children under 5 years are facing various forms of malnutrition, which impact their physical development and their ability to learn. Africa's leaders need to step up and invest in a healthier, more resilient future so that every child gets the food they need on their plate.
Welcome back, ladies and gentlemen. Before we begin the 8th session, we will first listen to a message from Melissa Fleming, UN Under Secretary General for Global Communication. Melissa, you may have the screen.
Dear friends, it is a pleasure to join you today from the United Nations headquarters in New York. At the UN, we have a vision for a better future, one of everyone on Earth living in peace, dignity, and equality on a healthy planet. And we have our roadmap to get there. The Sustainable Development Goals are the SDGs, and we are making some headway. More women breaking more glass ceilings in business, politics, and beyond. Renewable energy booming, already supplying 30% of the world's electricity. Internet access is up across the world. HIV infections down. New malaria vaccines have arrived that could save millions of lives. Yet as things stand, we are simply not going fast enough. Just six years out from our deadline, only 17% of the SDG targets are on track. Progress has stalled on more than a third, or even regressed. And at the same time, the world faces multiple crises and existential threats. Conflicts, wars raging across continents, and international law trampled. Mounting geopolitical tensions, a resurgent nuclear threat, and all the while, the climate emergency rages on unchecked. Developing countries desperately need the international community's help to make progress. They are reeling from economic shocks, surging inflation, and high interest rates. They are struggling under unmanageable debt burdens. One thing is clear. No single nation can solve these global problems alone. We need bold, coordinated action to secure our future in the interest of all. Yet, we are seeing many turn their back on collaboration just when we need it most. And we have a toxic information landscape, which is undermining trust in institutions, democracy, climate science, and vaccines. It's undermining trust in our blueprint for a better world. And all this is impacting the UN's efforts to make the world a better place, whether it is climate disinformation that is being used to discredit the green energy transition, or gender-based hate pushing women out of the public sphere, or also hate-filled narratives that are spurring violence. But there is some valid criticism too. Global governance is outdated. It's designed for an older world. And that is why the UN is seeking to breathe new life into the multilateral system. This month, world leaders are going to be gathering here in New York for the Summit of the Future, a chance to shape our world together. The summit seeks to turn a new page on international cooperation and looks to wide-ranging agreements to chart a path forward on sustainable development and the climate crisis. First, we need global governance that can meet the challenges of today and tomorrow. The summit seeks to reform international structures to better reflect geopolitical realities. Second, we desperately need peace in Gaza, Ukraine, Sudan, and elsewhere. The summit aims for a rethink of collective peace and security to end wars and prevent new ones, especially nuclear conflicts. Third, we need to harness the benefits of digital technologies, including AI, and mitigate their risks. The summit will discuss ways to ensure new breakthroughs to help all of humanity. Dear friends, these are our ambitions for a better future, to meet our responsibilities and those yet to come. Too many of our decisions today are knowingly harming future generations, whether that is the 1.9 billion young people alive today or the 10 billion more projected to be born by the end of the century. These people have the most to lose if we fail, but they are also the key to our efforts to restore hope and rebuild trust in our future. Increasingly, the world looks to young people to drive societal change, for breakthroughs on climate action, racial justice, and gender equality. But too often, young voices are left out of decision-making. And that is why the UN has created a youth office to coordinate inclusion. And we hope that the Summit of the Future will set a new global gold standard for meaningful, youthful engagement. A declaration for future generations that will be decided at the summit seeks to ensure our decisions today don't negatively impact our future generations. The meetings this September are just the beginning. They will set the stage for a crucial year to come, especially when it comes to the climate crisis. And here, young people have been leading the way. And now that energy and ambition must be matched by the biggest emitters. So at COP29, developed countries must deliver on their finance commitments and offer big contributions to the new Loss and Damage Fund. And they must build on current momentum, fairly phase out fossil fuels, end fossil fuel expansion, and accelerate the transition to renewables. Dear friends, we cannot let up. It is on all of us to build a better future. And so, as you reflect on the state of our troubled world, keep focusing on constructive solutions and celebrate ideas that can help us make good on our promises. Now is the time to end poverty, stop wars, and protect the planet while leaving no one behind. Thank you.
Thank you, Melissa. Now let us begin the next session, Heal the World, Last Mile Issues and New Challenges. For that, we invite the session moderator, Rodney Kelly, Japan Ambassador for Scottish Business Network, mentor at the Cambridge Judge Business School, and Senior Advisor at Health Innovation East from 2021 to 2024. Without further ado, Rodney, you may have the floor.
Thank you very much. And good morning, good evening, good afternoon to everyone joining from around the world. As was mentioned, this is the 8th session of the Global Town Hall, and this is entitled Heal the World, Last Mile Issues and New Challenges. We're very excited to be joined by an expert panel of very senior and well-informed experts, and we're going to be having a really interesting session around this topic of healthcare inequality, which was previously mentioned. The topic for today we're going to deep dive into is a topic that I think is close to many people's hearts and is an increasingly focused issue. So the World Health Organization, as you know, have identified that at least 4.5 billion people around the world still do not have actual full access to essential health services in 2021. And according to UNICEF, 14.5 million children did not even receive a single vaccine in 2023. We're going to be talking about that inequality of access. We're going to be talking to the experts about some of the tangible solutions that we can bring and listening to their expert opinions. So today we're joined with a wonderful panel who I'll very briefly introduce. So we have Professor Aditama, who is the Director of the Postgraduate School of Universitas at ERC and was the Acting Director of Communicable Diseases for the World Health Organization Southeast Asia Regional Office between 2018 and 2020. We're also joined by Dr. Hamid Jafri, Director of Polio Eradication, World Health Organization, Eastern Mediterranean Region. Masao Takahashi, Head of New Investors at Gavi, the Vaccine Alliance. And finally, Andrew Dembe, Founder and CEO of Mobi Clinic. So a warm welcome to all our panelists. We're going to do this session, as I said, in two parts. We're going to have a moderated session to start, in which I'll be asking the experts some questions and hearing their feedback from their point of view, followed by a more open town hall, where we're going to bring in some discussants who I'll introduce at the time, who can dive deeper into the topic. So with no further ado, I'd like to start with our first question, which would be addressed to Dr. Aditama. Dr. Aditama, welcome, and thank you for joining us.
Thank you for inviting.
Good morning, or good evening, where you are in Jakarta. So this is a very broad question about the post-COVID-19 world and the era in which we're living now. Our question really to you is about, from your opinion, in kind of two sides, what did we learn from the pandemic, and how are we situated as a society to either prevent or deal with or even recover from another pandemic should it happen?
So thank you, Raji. So also thank you for inviting me to join into this important global town hall. So regarding the important discussion or question regarding post-pandemic era, because this is quite discussed in every occasion, at least in my opinion, we have to go into three possibilities. I mean, three categories. The first one is in the community, second one is in the country level, and the third one is in global level. So I will just discuss in a short time that we have one by one. In the community level, in lay people issue after the COVID, at least there are two new things that happen. Number one is awareness. Now people are aware of the problem, aware of there is a potential pandemic, aware if there is some disease somewhere in the world, it could transmit to other people, other places. In a good sense, this is good. So because now if there is some cholera in some part of the world, then people or journalists call me, how about the disease in that, will it go to Indonesia? Before there was no those kind of questions, but now people are aware of that one. It's good that they're really aware of that one, but sometimes it is I mean, they make them panic. So there is a balance on that one. A good, that's the first thing about community. The second thing about community is about the healthy lifestyle. You know, in COVID, everybody put priority on their health because COVID is very scary at the time. So people give more priority to their health. So now after COVID, some people are still doing so, but some are, you know, they come back to the life before COVID. I keep saying to my Indonesian colleague, of course, economy is important, politics is important, but see, during it's not everything, but without health, everything is nothing. So these two things is happening in community right now. So I do hope, and we do hope, that people keep increase their awareness. In a sense, they know that diseases can transmit it from one place to the other, and hopefully they still put health as their priority in life. Besides, they have to do their daily life. That's in the community level. Secondly, is in the country level. During COVID, there is a clear multi-sectoral approach. I mean, not only health sector that working to tackle the COVID. Every part of the government working together to tackle the COVID. So this is after COVID, aspect, I mean, sector non-health, you know, now become aware that, okay, so health is important, but their active participation to health is not as good as COVID. Of course, we do not want everybody to talk about health. Okay, they can do their own, but please put health as in their mind if other sector also doing their activities in their field. That's the first one about community. Second one, again, during COVID, health is a real priority of program, priority of budget, etc. Now, after COVID, then things, quote unquote, back to normal. So we do hope that every country could, give health a priority in their country program. That's country level. So my last point is about the global level, or yeah, you can say regional or global level. As you may know, that Indonesia on 2022 and 2023 become the chair of G20 and then become the chair of ASEAN. So on those two regional, even though G20 is not regional, but on those two occasions, Indonesia play an important role. And pandemic preparation, as you mentioned, pandemic preparation is always discussed, is always come during discussion. Even on the ASEAN leader ASEAN meeting, there is an ASEAN Minister Health declaration on One Health. So and during the ASEAN leader declaration on One Health, the topic of pandemic preparedness and response was raised quite high. And we also know that the pandemic fund discussion was also quite heavily discussed during the G20 meeting. So something already, not something, many things already happened in that sense. That's the first aspect of global. The second aspect I would like to mention about global is we all know that on December 2021, WHO, all countries in WHO agree to establish a new pandemic agreement or pandemic convention. And at that time, their target was to have this new convention on agreement on this 2024 WHA. In the meantime, not only talking about pandemic convention of agreement, but people are also talking about the amendment of the international health regulation. So quite fortunate. We are quite happy that on the 1st of June, the amendment of international health regulation already in place. So now in the international health regulation, we have the definition terminology of pandemic emergency. On the previous ISR, there is no such kind of definition. So that's good in a sense. But the pandemic convention / agreement still under discussion. The target now moved to 2025 or at least December 2024. And if I'm not mistaken, the next discussion will be on 9 September. And again, One Health is discussed. One Health is still heavily negotiated. So we do hope that beside the ISR amendment, there will be also a pandemic, you can say agreement, convention, or treaty. So we globally can prepare better for the possible of the coming pandemic. So that's
Thank you.
my yeah.
Thank
Over
you.
to you.
Thank you, Dr. Atitama. That's very wise insights, and I think it's going to be exciting to see with the G20 and the ASEAN chair with Indonesia how that community level and base and global level plays out, and I'm sure we'll see lots of good results from that. So thank you very much. I'd like to direct my next question to Dr. Jaffrey. Dr. Jaffrey, thank you again for joining us. Again, we're talking here about a very broad question about the last mile challenges, and again, ensuring universal access to healthcare. In your opinion, how's it going? What's hindering it? What could be helping it?
Thank you, Roddy. So I'm pleased to be here on this panel. So, the last mile challenges come into very, very sharp focus in polio eradication because of its imperative to reach every child, every family. Polio eradication is in fact the ultimate in health equity and universal health coverage, really. You cannot succeed until you have reached every last child. The polio virus is very, very unforgiving. It will reach and paralyze those children that the program cannot reach. So with 99.9% reduction in paralytic polio from around 350,000 cases in 1988 to just 12 cases last year caused by wild polio virus, the program has been in an extended last mile for years. Again, because of our imperative to reach everyone. The paradigm holds true at the global level, at the regional, national, subnational, and even community levels. So, by the year 2000, only 5 countries remained endemic for wild polio virus, compared with 120 in 1988. Just Afghanistan, Pakistan, India, Egypt, and Nigeria remained endemic. And between the year 2005 and 2020, 15 years, 3 countries came off the list of endemic countries: Egypt, India, and Nigeria, in that order. And Afghanistan and Pakistan remain polio endemics. We really are facing last mile challenges. And what are those last mile challenges from the perspective of polio eradication? I would broadly characterize them into 4 areas. I think the first is the lack of access to children due to insecurity, conflict, militancy, or political reasons when vaccination is banned by local authorities that are controlling a part of the country. And this is something that is posing formidable challenges to reach children in some of the countries of the region that I am working in, the Eastern Mediterranean region. That includes, of course, all of the Middle East, Horn of Africa, and Afghanistan and Pakistan. Second, within countries, there are marginalized populations, the poorest and the most disenfranchised, who are hard to reach because they are constantly on the move. They migrate frequently, often across international borders, and avoid interaction with authorities. Third, the social disconnect between the program and communities that are the most deprived of civic and health services. Communities that boycott out of frustration, communities that don't trust the vaccine, or the authorities that are providing the vaccine. And then the fourth area is the gaps in basic program implementation. That is the failure to map and reach all children wherever they are. And of course, failure to build bridges with hesitant or frustrated communities. So how is the polio program dealing with this? So we have extensive experience and we continue to innovate to overcome these last mile challenges. The program maintains neutrality and negotiates with all parties in a conflict to vaccinate children. This is how polio has been eradicated in many conflict affected countries, and outbreaks of polio have been stopped in many countries with civil strife and militancy, and in areas that are not under the control of the government. Recent examples include Syria, Sudan, Somalia, Nigeria, and you have been hearing, of course, the current news out of Gaza. Secondly, the elaborate strategies and tactics that we are working on to define and map migrant and mobile populations with constant innovations to track, engage, and vaccinate these very hard to reach populations. Thirdly, we have learned very important lessons and experiences in engaging alienated communities and build bridges. The first 3 principles are listen, listen, and listen. And then, of course, integrate other health services or provision of essential items with vaccines. Make the communities partners and part of the program. Recruit local workers, empower communities, and give them agency to protect their own children. And then finally, program quality and effectiveness and ability to reach every child really depends on national and local commitment, monitoring and evidence-based timely corrective actions, and performance accountability at each level. And of course, the most important is motivation and training of the vaccinators, community workers, and their supervisors. That is where it all comes together for failure or for success. Back to you, Rory.
Thank you. Thank you, Dr. Jaffrey. And I'm hearing that about accountability, which really brings us on to our next question, which is about accountability and prioritization and what governments are doing to prioritize it and how they're evidencing this prioritization. So thank you again for those insights. So I'd like to bring in Masao Takashi. Masao, I'd like to ask you a question again, leading on from Dr. Jaffrey's point about accountability, and it's a broader point about government prioritization and people prioritizing. So my question would be, how would you describe the current state of global health, and how and where are governments really prioritizing global health and health within their systems?
Thank you very much. I think that from our perspective, I mean, many people think that, the COVID-19 pandemic is already over. But if then the reality is this, that the many regions, many parts of the region, the world, still that those health system is under the pressure, and then we really need to do so many actions in place. And then especially that given the current situation in light of the pandemic, there are still many things that we must all work together to ensure that we do not repeat the same challenges when the next pandemic hits to us. So some countries, those immunization rate recovered to the previous pandemic, pre-pandemic levels, but still some middle-income, low-income countries struggle to bring those numbers back to the place, which means that vulnerable groups, including children, are at risk of the preventable diseases. And additionally, the issue, as Dr. Aditama mentioned about G20, I just wanted to bring this up, is this issue of emerging infectious diseases and AMR, this kind of stuff are also the critical challenge. We are in the critical challenge of threatening the global health security issues. And then not only by the WHO, but also in the multilateral forum, like G7 and G20, they have been constantly discussing on this. In this agenda, actually, the prevention and the immunization played also the crucial role. I just wanted to share this perspective because I'm working from Gavi. And then Gavi, one side, we've been working on launching the special programs, the zero dose children programs, to enhance, to reduce, accelerate those challenges, to improving the situation in this strategic term. And we're running on the program. And then perhaps for the prioritization piece, absolutely that the global health will be the key, and we should continue prioritizing this no matter how it goes, because we already have seen that we live in the hyper-connected social systems, and then public health is the foundation for the economic stability and social development. We already witnessed this in a few years ago. And then if you go deep dive a little bit on this, then from the health topics, that there are aspect of the cure and care side, and then the cure for this accessing to the health system, that we're able to make sure that people have equal access to this. But also that the care side is we emphasize the prevention through those, and not to have people getting into those health systems. And we both have to have this two side and then in parallel to work on this, but that requires the system transformation. So some people work for this at the cure side, but some people for the care side. We all have to work together toward the same goals, and that's a transformation which is challenging, but we have to make it happen. And then lastly, just wanted to touch upon a little bit on this, the Gavi's, in this context, what Gavi tried to do. Gavi launched those new strategy 6.0. We call it Gavi 6.0 for the strategy, for the 5-year strategy, 2026 to 2030. Gavi, since the launched in the 2000, we have been immunized 1 billion children for this 2 decades. And then the next decades we envision to immunize the 1 billion children in the 10 years. So which means the double speed on this. So to make those things happen, we need to work closely on those system reforms, and by perhaps working together with the other international organizations and then the other governments, and then also bringing a lot of innovation into this context. So that the last mile delivery will play a crucial role on this context. And then lastly, I just wanted to mention that which we all, from the international organization perspective, we work very closely with the other international organizations, like from the Gavi's case with the Global Fund, the UNITAID, and then there's also the CEPI and many other organizations and WHO. But that's one side we work with, and also we work closely with the government. But what is critical for us to keep working on this sustainable manner is the political support from each government as well. So just because of just looking at the new leaders who are on this session, I guess that which is important. This could be also the important piece to echoing this, and then keep having the support from the political support side as well. Yeah, I just wanted to stop here at this moment.
Yeah, thank you, Masao. And I think that's it's a point that has come up both from Dr. Aditama and Dr. Jaffrey and yourself about mapping and understanding the size of the task, so that concerted efforts and multilateral efforts can be joined together to tackle this. We know that in July, the UNICEF and World Health Organization published some very interesting data that showed a very patchy global landscape of those who have and those who have not got access. So with your initiatives with Gavi and the 6.0, and again, forums like this where people can come together and really lock arms and say, how can we approach this as a society, I think are very useful. So thank you very much for your insights.
Thank you.
Thank you. So moving on, I'd like to bring in Andrew Dembe. Andrew, I have a question. Again, this is another broad question about those last mile challenges about ensuring universal access to healthcare. But I'd like to have a more specific look at some of the work that you've been doing with Mobi Clinic in Uganda. So it would be great if you could just open up a little bit about some of the biggest achievements that you've had over the last 5 years since it's been in service, and perhaps how other health organizations or entities can learn from what you've done so that we can share the learning.
All right. Thank you so much for the question, Rodney. And I'm happy to be here to share my views about last mile issues. The work we do at Mobi Clinic is work that is meant to improve last mile health delivery. And we diagnose the problem across sub-Saharan Africa, here in the global south. We saw that many people live in rural areas, rural last mile areas. And when you go down to these places, for instance, in Uganda, where I'm based, where I come from, we have 8 out of every 10 people living in rural last mile areas. So the bulk of our population in Africa, in Uganda, is, it belongs to the last mile areas, yet they struggle with access to basic health services. Now, the major issue here is the basic in quotes, because something as small as detecting malaria is hardly accessible in these areas. And we saw that 2 major problems are underlying. Number one, there is a problem of few medical workers in these areas. And the medics do not love to work in these areas because of poverty. The areas have low purchase power. There is gross poverty in these areas. And so they do not find meaning in putting their private practice clinics in there. And yet governments in sub-Saharan Africa are struggling with resources to put there enough hospitals for people. So what happens is that the second problem we face is that people find that hospitals are far from them. So because they see that hospitals and health facilities are very far from them, people decide to do a lot of self-medication in their communities. And so even the children who are meant to get vaccines sometimes are not taken for immunization. So there is so many layers of the problem in terms of accessing basic health services. And so after seeing this problem being very prominent in Uganda, but also across the African continent, at Mobi Clinic, the team was like, what can we do? How do we come up with a homegrown solution that responds to the problems that we have witnessed in these communities? And some of us have grown up in these communities. So that is how we came up with home-tailored solutions to say, number one, the numbers of doctors are not going to be enough for us, even if we wait for the next 100 years. Because the few doctors that are trained are always, leaving our country and Africa, going for greener pastures elsewhere. And that's a reality. So the big question is, how do we work with what we have, to attain health equity, a model that enables, equity for majority, for all. And this is where we said, look, let us decentralize the basic healthcare skills and the knowledge down to the communities, to the people. Let us work with the public health systems to ensure that people in these communities are getting skilled in terms of first line care. And let us create a network of well-trained first-line caregivers. These can help out the different segments of the population. They help out the pregnant women, they help the children, they help the elderly, and everyone benefits once there is someone in their community who is skilled in terms of first-line care service delivery. And after that, we said, okay, what can we do about the fact that these people have been trained to a certain level? Time and again, they will interface with conditions that are beyond their scope of training because they are not doctors. And remember, we have few doctors who prefer to work in the cities here in Africa. They prefer to work in the cities because the cities pay them much more handsomely than these other last mile areas. So that's where we said, okay, let's use technology because we can utilize the avenue of technology to get health equity. And we use tool that is meant for community health workers, wherein if a community health worker gets stranded, they use our tool to interface with senior medics. So doctors in the comforts of their offices in the cities are able to interface and guide first-line caregivers in their communities. So our tool is robust in nature. It helps out the first-line caregivers in terms of taking in terms of diagnosis of the patient, but also recording their information. And also our tool can be used for integrated referral. We do not work in isolation. Our major aim is to strengthen the local health systems. And that's why even on our tool, we onboard the existing facilities, the health facilities, hospital, be it for government or private, such that when a community health worker is stranded, they know where to refer this patient. And also our tool supports them in terms of critical emergency. They are able to use it to call for an ambulance. And all this is what we think that we need to do in our communities of low resource setting. Because the big question is, yes, we are under-resourced, but our school of thought is that despite the small resources, we can work around the model, circumvent, the challenges and be able to create an equitable model, empower the community, and then leverage technology. And that way we have an approach that is from bottom to up. And this is what we've been doing at Mobi Clinic. At Mobi Clinic, over the past 6 years of our existence, we have created a network of 1,200 community health workers in the areas of Buyikwe in eastern Uganda. And the power of one is very important because one community health worker can reach out averagely to about 200 to 300 people per year. So that is the power of empowering one person to serve their immediate family and the community around them. And so to date, we've served over 250,000 people in our Mobi Clinic work, despite the very small resources at our disposal. And that's why we think that our model is cost effective, and we are working towards attracting governments to work with us and also the players who are in the health industry, because we believe that when we work together, we can be able to unlock access to primary health care access in these areas. So that's the overview.
Thank you, Andrew. And that's fascinating to see the innovation that you've been driving out into the community and navigating some very difficult landscape and geographical last mile issues. And it's a textbook example of innovation mindset being able to join. And I'm sure your journey will continue and you will get that overall investment and interest from a global audience and learn from what you've done. So thank you. That's very fascinating insights. So I'd like to move us now on to open up this discussion more. And thank you all to our panelists for their great insights. We're now going to give a chance for some of our broader audience to come in with some questions or some comments in a town hall format. And I'd just like to introduce some of the discussants who will be asking questions and making points. So we're joined by Dr. Kanika Raka, Assistant Professor at the Kautilya School of Public Policy. Good afternoon, good evening. Dr. Azrina Raman, Head of Public and Social Policy at the Center for Strategic and Policy Studies, the CSPS, and Lasisi Godwin Ona Olapo, founder of the Interfaith Alliance for SDG Action Plan and at the West African Institute of Public Health. So welcome to you all. We look forward to hearing your observations and your questions. I'm going to, with no further ado, pass it over to Dr. Rakra. If you would like to ask your question or make your point, over to you.
Thank you so much, Rodney. I actually enjoyed a lot of what the speakers made comments on, and I had 3 questions for each of our first 3 speakers at least. But before I begin with the questions, I just wanted to make a sort of short point on how health has also become a part of securitization of structures. We see how all international organizations, all issues have become securitized, whether it's climate change, and similarly, health is also coming into that foray. I teach foreign policy, and which is why I understand how health is becoming more and more relevant and global in its own understanding. In this context, I would like to point out how the Quad has actually come together to build on an alliance, first as a vaccine structures, and then as a sort of health security architecture that is trying to work on. So the vaccine alliance was quite successful in 2023 when it was announced, and it's been taken forward in 2024 in a more substantive manner. And it is in this context actually that I'd like to ask Masao first, how do multilateral organizations then understand these minilaterals or trilaterals that are coming up and their engagement with health security? How is it going to impact organizations like Gavi engaging with global public health? My second question is to Dr. Jaffrey. Actually, it's more a comment than a question, rather, but you mentioned how polio was there in India, Pakistan, and Afghanistan, and India has been able to successfully eradicate polio from the country. And I just wanted to bring out that a lot of that had to do with positive advertising and a sort of relentless work by the government at the local level, something that Andrew was also pointing out to, where there was persistent and consistent approach to engaging with polio by the government. So that actually helped push. It's not really a question, just a comment. And my third question rather is to Professor Aditama. I actually wanted to ask you, you mentioned about the pandemic treaty and you also mentioned about the G20. I had the privilege of working with the Secretariat when Indonesia was going through its presidency and also when India was going through its presidency. So I actually saw a lot of those debates on health securitization and engagement and how that happened. A lot of what we are observing now is that, especially with the pandemic treaty and with financing for health engagement at a global level, is not finding the same level of takers that it did in 2021 and 2022. That already is reducing, and it's also reflective in the sort of global at the national level. So maybe all of your comments on each of these points. Thank you.
I'll pass them over. Just a request to those answering, if we could try to keep them as short as possible, just for expediency. Thank you. So over to you, Masao-san, your question.
Thank you. I thought you were going to give me 1 hour, but okay, then maybe I'll try to keep it short. I think just then a little bit focus on some of the, I may not be able to answer fully, but I just wanted to elaborate first on this context. What Gavi has been doing is balancing the demand for the vaccines and also the supplies. And then that helps us to reduce the cost. And because of this stable supply will help the vaccine manufacturer to make a necessary investment and at risk. And then the Gavi also makes sure to stabilize those demand, those purchasing and advanced purchasing commitment that help those the purchasing the vaccine lower price, but also help building those capacities and then making those the manufacturer to have a sustainable business models there too. That's good for the societies. So by doing this, I think that's a true, I believe it's a true private-public partnership. But by doing this, let's say the routine routine immunization, those vaccines, which cost in the market $1,300 US dollars equivalent in the US market, we procured those amount of those vaccines, $24. So which kind of lowering the cost, which means we could provide the more accessible access to those vaccines to the people. That's the global scale that we've been operating on this. So how does those regional perspective coming in is one side, as we already one side there's global purchasing powers will help to reduce the cost and stabilizing, and then preparing the necessary manufacturing site, looking at those climate change and health. We have this vector-borne diseases like malaria, yellow fevers. We started to see more of the outbreaks. Then we may need more the more vaccines in the future. So we need to have some adjustment of the global productions and those scales and also those supplies, and these elements in one pot. So the one side we can do it in the global scale, but also that we already witness in the COVID-19 context that there's some countries like Africa, for instance, we do not have a vaccine manufacturers, and we're going to be having some troubles when it comes to those next pandemic. So this regional component also played a quite important role. So we try to balance this manufacturing, what we need for the global manufacturing for the sustainable manner, but also that without pushing too hard to balancing those regionalization to have a diversity and then to be ready for the next pandemic. So the short answer, this is something we try to balance in. That's how we've been working as a Gavi to try to contribute to the global context.
Thank you, Masao. I hope that answered your question, Dr. Rakra. I think we'll just have time, sadly, just for one your next question, perhaps not your third. So Dr. Jaffrey, I believe Dr. Rakra had a question about polio.
Just two very quick comments. I think first is that, in fact, I was leading the WHO extensive team in India when polio was eradicated. And I think the three things that came together very well was that at the local and state level, we had motivated governments, and WHO and UNICEF were providing technical assistance and monitoring data for corrective actions. And then these officials were ready to take corrective action. So that circular program optimization worked really, really well in some very difficult areas. I think my second point about relating health security to polio eradication is that given the very local presence, at the community level of polio workers, in critical geographies when the pandemic started, they were the first responders, both for surveillance and distribution of PPEs. And of course, for testing and surveillance. And that's basically is what builds health security when you have trained people on the ground. Thank you.
Thank you, Dr. Jaffrey. I think we could have Dr. Aditama, if you would like to pick up the question about pandemic treaty in just a couple of sentences, and then that'd be great for Dr. Rakra.
Yeah, just in short, half minute, maybe 1 minute. Number one, the debate about the pandemic treaty sometimes might not be proper because we do not have the treaty yet. It might be convention, it might be agreement, it might be a treaty. But people are very sensitive with the definition of treaty. That's number one. Number two, regarding the financial aspect I just want to see the positive aspect of that one. The positive aspect is that people are already now concerning where the financial come from. Of course, it's not really implementing, but anyway, let's just see the positive aspect and on the financial and fund. And certainly in this new pandemic agreement, those kind of funding and financial aspect and how it's distributed, equally, not equally, balancedly between countries are also already discussed. So let's put it a very good progress. Hopefully it will progress better in the future.
Thank you. And that's good. That's a positive note to end your questions on, Dr. Rakra. Thank you. I'd like to now bring in Dr. Azrina Raman, who has some questions or comments to the floor. So over to you, Dr. Azrina.
All right. Thank you so much, Rodney. And thank you so much to all the speakers. I've learned a lot today. Unfortunately, the session is quite short, so it seems to be rushing around. I think with the pandemic, obviously, we've learned a lot in terms of preparedness. and how to be ready for the next pandemic. Usually the vulnerable groups that's still going to be affected most in the future as well. Andrew's work with the Mobi Clinic was fantastic. I mean, working with very little resources, trying to get to everyone is really well done. I do hope that you will be supported even more in the future to, push for your work, because usually it's you hear of these African, third world countries that actually is requiring more help compared to other countries. Just a question to Professor Aditama. I mean, Indonesia is such a big country. I'm sure there are many vulnerable groups that you find hard to actually get to in terms of during the pandemic. I was just wondering if work like Andrew's work, like the Mobi Clinic, is that something that is being practiced in Indonesia as well to, get to these remote places and so forth? Yeah, I just have one question. Thank you so much.
Thank you, Dr. Azrina. Dr. Aditama, would you like to pick that up? I'm not sure if, I think he may have frozen. He was either very pensive, but I believe your question is Indonesia, with its sprawling geography of 17,000 islands and the difficulty of that last mile problem, which I'm sure is not dissimilar to what Andrew and his team experience in terms of getting vaccines out there. Your question is this something, the Mobi Clinic Uganda model, is it being practiced in Indonesia? I think Dr. Aditama has perhaps frozen. So what we'll do is we'll maybe put that on the back burner, and should he rejoin, we can ask him once he comes back in. But yes, thank you very much for your, and we'll move on. I'm sure he'll rejoin in a moment. So thank you. So I'd like to move on to Godwin. Godwin, I know you have a question or a point you would like to ask the panel. So good morning, I believe it is in your time.
Yeah, thank you. It's morning here. Good morning to everyone, and good day. My name is Lassie Sigurd, and I must commend you. I mean, you pronounced my name pretty correctly, so thank you for that. You did a great job. My question is actually also three. To issue for the speakers who spoke. I'll be coming from the context of, the African background. I'm talking about Nigeria in particular, because you're looking at the last mile, and I would be underestimating when I say COVID literally changed the world. It basically changed the trajectory to which we see the world, the loopholes in our healthcare system on a national scale and on a global scale as well. So then, talking about the last mile, I would commend Andrew for the amazing work he's doing in Uganda. And then when you look at that, you're talking about the last mile in the rural context. And there's also the last mile on the global context as well. First to Dr. Jaffrey. Looking at the work the WHO does, I'm pretty concerned because yes, there was COVID, and then in battling this last mile challenges, there's also new upcoming emerging issues like climate change. I know recently, I think it was about 2 days ago, the WHO committee held a consultation for the special COP29 reports with the healthcare community. And I was trying to give recommendations based on rural efforts put in place to promote climate adaptation strategies and climate mitigation strategies. So I'm pretty concerned with the work that WHO does, how that relates to, because I think our goal is prevention. We do not want a situation like COVID where it hits us. So, and there's monkeypox coming up again. So we're looking at all these emerging health issues. So looking at emerging issues like climate change, and then looking at prevention measures, how do we battle that? So that's Dr. Jaffrey. And then, so Mr. Takashi, amazing presentation. I must commend you with the amazing work Gavi is doing. And I'm also concerned too, coming from the point of monkeypox. It's beginning, we hope it doesn't turn out to be a disaster like COVID, but then coming up from the concept of prevention as well and sustainability, because I believe we do not want one-stop approaches to solving these global health challenges. So coming from the point of sustainability and looking at sustainable approaches, vaccines are pretty much the perfect ways. We're not looking at cures, we're looking at prevention measures. So talking about advocacy, because how much persons and what's the population of, the global community in respect to rural communities who have knowledge about the existence of these vaccines before we begin to talk about access and then the quality of these vaccines, because I think that's two key important things. So talking about the quality of these vaccines and then the access as well, and then the quantity. So how then does Gavi handle all of this, talking about low income and middle income countries, talking about Africa, and then, the different climes according to the continent. And then Andrew, amazing work you're doing again, I must say. It's pretty amazing. It's almost similar to the work we do. I founded an Interfaith Alliance for SDG Action Plan, which is basically an initiative to have young people at the grassroots level using their interfaith beliefs to come together to, achieve the SDGs. We are falling far short. Agenda 2030 is 6 years short now. So, looking at our timeline and our intention to achieve all of these goals, I believe integration of these goals, probably, not on a whole scale. I'm talking about SDG 3 now, the targets that we have. What are the key point notes you've taken? Talking about success stories you've had. What keynotes have you taken in place to see that you could probably build upon? Because of course we're looking at expansion. Success stories have to help countries who are also in situation like yours. I might want to start my own clinic one day. Yours is Moby Clinic. I might want to start Godwin Clinic. So based on the success stories you've had, what recommendations would you suggest to individuals, world leaders? Because it's a pretty global town hall. So a lot of people are listening. So what keynotes would you take based on the success stories you've had? So just shed a good light on that. Basically, that's it. Thank you.
Thank you, Godwin. So I'll apportion the first question off to Dr. Jaffrey. Dr. Jaffrey, the question regarding prevention.
Yeah, I think the reality is, Godwin, that climate is changing, deforestation is happening, and ecology of diseases is changing as a result of that. So new diseases are emerging. So whether it is COVID or whether it is Mpox now, this is going to happen. So, and countries are struggling to decide if they will be just dealing with one disease at a time. So what WHO is saying is to develop systems and resilience first and foremost at the community level. Outbreaks start and affect communities. So that's at a community level, because that has to do with the kind of behavioral protection as well as tools. Vaccines and medicines alone are not going to do it. So there is a behavioral element of the communities, as well as, of course, preventive tools. Second is the system, public health system approach, so that you have to have strong surveillance systems. You have to have strong detection and response systems that are cross-cutting across diseases. In Nigeria, how many outbreaks are you having concurrently right now? Eastern DRC, multiple disease outbreaks. So you can't be fighting each outbreak alone. You need to have cross-cutting systems of public health. And then, of course, global systems that can supply countermeasures, whether they are vaccines and other tools. So it's a complex multi-system approach. I think gone are the days when we could just prepare for one particular disease or control one disease. You need cross-cutting systems to do that. And that's what the WHO's emergencies program is working towards. Back to you, Rodney.
Thank you, Dr. Jaffrey. And the second, and very much continuing on the topic of Mpox, Masao, I know you were asked by Godwin about Gavi's thoughts on Mpox.
Yeah, I think that it's going to be the partial answer, but what we have been doing, we learned from the previous the pandemic that when we created the COVAX, which to make sure that the equitable access to those COVID-19 vaccines, the biggest challenge was it took a while to start initiating those vaccine manufacturer to work on the manufacturing capacity increase and those investment, because the COVAX we launched, but it took a while to get the public funding to make those things take action on that. So we learned from this, and then we could accelerate this portion without waiting these things. So the Gavi created the fast response fund for the day zero financing that we are calling, so that as soon as we have triggered those emergencies, that the Gavi could make a decision. It also have to go through those decision-making process, though. That's the financing that those manufacturers to start producing those vaccines. So this hopefully that will reduce those timeline on that process that's been kind of in a coordination with with the other partners, with UNICEF and WHO, but this discussion is on.
Thank you, Marcel. Yes, that concurrent development at the same time of those work streams are extremely important, aren't they? Thank you. And I believe your third question was very much a kind of outreach, potential collaboration opportunity. You were talking with Andrew, and this is the value of these great forums, is that people can make these connections and think about how, you know, think tanks and individual organizations can work together. So Andrew, would you like to pick up the question from Godwin?
Yeah, if I got Godwin's question well, he was asking what's my advice for someone who would like to start out, work like Mobi Clinic in the communities? All right, thanks. So, pretty simple. Of my experience, I see three main things. Number one is leveraging collaborations. Collaborations with government structures is very important because it eases your work. Big central government or the local governments, because here in Uganda we also have the district local governments. So it's very important to use the public structures and to collaborate, especially while giving services to people who belong in the base of the economic pyramid, in the last mile areas. So that is extremely critical. But also collaborations with other players who have different offerings from what you're having. Collectively, then you have a stronger force. For instance, at Mobi Clinic, we have partnered with one of the largest telecoms here in Uganda, and it's offering health insurance, micro health insurance for people in the last mile areas. So leveraging collaborations is very important. And then the other one, obviously, is the team, making sure that the team you gather is passionate about solving this problem of health challenges in last mile areas. So I think those are very critical as you're looking at going out in these communities. And then what I beseech governments and the big organizations in the health industry is to give forum and platform to the innovators in some of these areas, to give them a listening ear. One of the speakers was very critical. I liked his point of listening and listening and listening. We should be listening to each other. I mean, the solutions are around us and are within us. So it will be very important for us to listen to each other, and we can create a world with better health equity. Thank you.
Thank you, Andrew, and that really does hammer home the sustainability of grassroots innovation and development. So that's an excellent point. Thank you. I wanted to give Dr. Azrina an opportunity to have her question answered by Dr. Aditama. So, Dr. Azrina, would you like to just very, very briefly ask the question again?
Sure. Okay, my question to Dr. Aditama was, because Indonesia is such a big country with all the islands, you know, I'm sure there's quite a huge portion of vulnerable groups that you have challenged to reach during the pandemic. So was there anything like what Andrew is doing with Mobi Clinic that was being mobilized during the pandemic time to address this? Or was there some other, you know, programs and so forth that was being implemented by Indonesia? Yeah, thank you.
Thank you. Dr. Aditama. Oh, I think you're on mute. Sorry.
Yeah. Okay. So thank you for the question. In fact, I'm not in Jakarta right now. I'm in the remote area as well. So that's the question. It's really, so I have some problem in my signal. So the problem of remote area is not only health, but also even the signal. That's the general comment. But we have three program. I mean, for people vulnerable or even in the remote area. Number one, the country. This is the number two. It's a special program for the remote area, including the vulnerable people. That's number two. And number three, because the question is specifically for COVID. As I mentioned earlier, during COVID pandemic, everybody working, not only health people. So even people on the kind of Department of Social or Army or Police, they help everybody, including the vulnerable people throughout the country. So that's my short answer. And sorry for the problem of my signal.
Thank you, Dr. Aditama. And I think that is a good opportunity and a positive note of everyone working together as they were in Indonesia to get that last mile problem solved. And I believe everyone on this call is actively working towards making those collaborations and working in a collegiate manner to bring these solutions globally. So thank you all very much for joining. I'd like to say thanks to all the panelists and all the discussants for joining, and all the members of the public who listened in. And thank you to everyone at the FPCI for organizing this great event. And with that, I'd like to say good afternoon, good morning, good evening, and thank you very much. Thank you.
Thank you, Rodney, for moderating the session. Thank you, ladies and gentlemen, for tuning in to the session on Heal the World, Last Mile Issues and New Challenges. Our next session is on food for thought, recipes for global food security amidst crisis. The session will begin in a few minutes, so please stay tuned.